for class P and class R. Okay, so students from both classes are connected, class P and class R. Can you please tell me? Class 1 and class 2, are you connected? Can you please answer?
We are connected, but somebody cannot go to the app because the internet have problem and the Zoom have problem, so they can go to with us. But now we have 44. The other one can go into.
Okay. So class 1 and class 2. Okay, so we have to start because the class is very long, very long, and we don't have enough time. So in this class, we are going to study RNA viruses, and they have in common is that all of them are respiratory pathogens. So today, we start with the study of RNA viruses. They are a lot. They are a lot. So many. We classify them also in two groups, envelope and non-envelope. All of them are single-stranded, all of them, except one that is double-stranded, reoviruses. So this is the opposite to DNA viruses. All DNA viruses are double-stranded except one that is single-stranded. RNA viruses are the opposite. All are single-stranded and only one is double-stranded. Today, we are going to study only the respiratory pathogens, the family Orthomyxoviridae that is placed here, and later we will study three viruses that belong to this group, the family Paramyxoviridae and the family Coronaviridae, all of them respiratory pathogens. So we start with the first one, Orthomyxoviridae. Orthomyxoviridae contains many different viruses, but we are going to focus only in one, in influenza virus. Influenza viruses that infect humans are three. Two are more important, influenza A and influenza B. And one is not very important, influenza C. From these viruses, from these influenza viruses that infect human, A and B, the most important is influenza A. This is the most important and possibly the most severe of these three respiratory pathogens. Influenza viruses are very common in the world. They cause a very common disease that is called influenza. Influenza is an epidemic, acute respiratory disease that you already know because we suffer epidemics every year. About the structure of the nucleic acid of the family Orthomyxoviridae, influenza viruses, you have to remember one thing that is very important. I told you about this in the first class about viruses, but I told you that we are going to explain in more detail today. The nucleic acid of influenza viruses is single-stranded RNA, negative sense, so class 5. But the most important feature is that they have a segmented genome. This is the most important feature. What is the meaning of this? What is the meaning of segmented genome? The meaning is that the nucleic acid, the meaning is that the genetic information is contained into different molecules. The genetic information of the virus is splitted, divided into different segments. For example, in the case of influenza A, they have 8 segments. I show you here. So the genetic information is not found in only one molecule as other viruses. The genetic information is found in different molecules. So the genetic information is divided into segments, and these segments are independent from each other. So These are not copies of the same genetic information. These are segments, parts of the genetic information. That is the meaning of segmented genome. Very few viruses have segmented genome, very few. Only orthomyxoviruses, influenza viruses that we studied today, Bunya viruses, arena viruses, that unfortunately we don't have time to explain because the class is very short, and reoviruses. They also have segmented genome. And segmented genome has a very important advantage, very important. Because the genetic information is divided into different segments, when different viruses infect the same cell, these segments may undergo a reassortment of segments. This is called antigenic shift. And they can produce a new variant of the virus. We will study later when we study the pandemics of influenza. Do you understand the meaning of segmented genome?
Yes.
Koha, do you want to say something about this? I'm not very sure.
Can the influenza segmented reassortment happen in animal or just human?
In animals and humans, both. I will explain you later.
Virus mà có segmented có nghĩa là nó có cái cấu trúc gồm nhiều cái đoạn khác nhau đó các bạn. Ví dụ như đối với virus cúm này nó có tới 8 RNA, còn non-segmented có nghĩa là nó chỉ có duy nhất một cái phân tử RNA hoặc là DNA trong đó hay thôi. Nó nghĩa là phân đoạn các cái đoạn này nó tách rời riêng ra.
Do you understand the difference between segmented genome and non-segmented? This is the most important. About the microbiological features of these viruses, this is the most important to understand. If we don't understand the meaning of segmented, we will not understand anything about the pandemics later. This is very, very important. Okay, so we continue. So, negative sense, single-stranded RNA. Okay, 8 different segments. Influenza A and influenza B viruses contain 8 segments, independent. Each one of these segments has its own capsid. So 8 segments with 8 capsids, 8 helical capsids. Well, influenza C, that is not important for humans, has only 7 segments, but this is not important. So remember, 8 segments, each one with its own capsid. And they have envelope. They have envelope. And the envelope contains glycoproteins. The most important of these glycoproteins are 2, hemagglutinin and neuraminidase. Hemagglutinin is the glycoprotein that the virus uses for binding host cell receptors, and the neuraminidase is a glycoprotein very important in the release of the virus, so in the last step. Influenza A viruses contain only influenza A. Influenza A viruses contain different types of hemagglutinins and neuraminidase, and this is very important. So look, what about hemagglutinin? Currently, 18 different hemagglutinins have been described in influenza A. We call them with the H letter and a number. So H1, H2, H3 until H18. So different influenza A viruses may contain different hemagglutinin. The most common in humans are type 1, type 2, and type 3. Hemagglutinin binds host cell receptors. What about the other glycoprotein, neuraminidase? Neuraminidase is a glycoprotein, it's an enzyme, and currently in influenza A, we can find 11 different neuraminidase, from N1 to N11. The most common for humans, N1 and N2. There is another one that is called M2 ion channel protein that I am not going to explain in the class. You can read later. This is not so important. So look, naming influenza viruses is difficult because they are so different, very, very different. We have 3 types, influenza A, B, and C. Some of them can infect animals and some of them humans. So we have to differentiate influenza viruses that infect humans from influenza viruses that infect animals. And they may be also different depending on the place where they have been isolated for the first time. So when we give names to influenza viruses, I show you here some examples. The first name that we give them is the type of influenza, in this case, influenza A. The second name that we give them is the animal where they were isolated for the first time, in this case, the quail. The third word that we use is the country where they were isolated for the first time, in this case, Vietnam. This number is the number of strains at the laboratory, and later, the year when it was isolated. And finally, the type of hemagglutinin and the type of neuraminidase, in this case, H5N1. This strain of influenza A that I show you here, this is real. This is a typical influenza A strain that infects some birds. So influenza viruses are respiratory pathogens, mostly for humans, but they may be also found in mammals and in birds. What's the problem with influenza A? What's the problem? That they can change their genetic information many times. The genetic information of influenza A viruses can change by 2 different mechanisms: antigenic drifts and antigenic shifts, both. And what's the difference of this? Antigenic drifts are small changes. These antigenic drifts are produced by mutations, small mutations in the hemagglutinin gene or in the neuraminidase gene. But these changes are very small, not very important. Every year, antigenic drifts are produced in influenza A viruses, every year. However, they may also change by a different mechanism, very important: antigenic shifts. Antigenic shifts are not caused by mutations. They are caused by reassortments of segments, I told you before, and these reassortments of segments appear when 2 or more different strains infect the same host cell. So a new strain is produced. This is an antigenic shift. This only happens in influenza A viruses. We don't know exactly why influenza B and C do not undergo antigenic shifts. We don't know exactly, or I don't know. So antigenic shifts are found only in influenza A viruses. When a new strain is produced, humans are susceptible to the new strain, and a new pandemic of influenza may appear. The last pandemic of influenza appeared 10 years ago, in 2009. It appeared in North America and it was spread to the whole world. That is the last antigenic shift, the last pandemic that we remember. We suffer pandemics of influenza every 10 years, more or less. The last one was in the year 2009. So look, in this picture, I show you the difference between antigenic drifts and antigenic shifts. Antigenic drifts, small changes, mutations of hemagglutinin or neuraminidase. Antigenic shifts, large, important changes, reassortment of segments when different strains infect the same host cell. In the link, I show you 2 videos where we explain the meaning of antigenic shifts. We are not going to watch the videos because we don't have time, but you can watch at home. I hope that you have watched them. So when, in this example, when three different influenza A viruses infect the same host cell, the segments of these three influenza A viruses may be reassorted and create a new strain. This is an antigenic shift. So this new strain is totally different to the original strains. Because this one is different, humans are susceptible to this new strain. We may become infected very easily and we may suffer a pandemic. This is the origin of all pandemics of influenza that we have suffered. This is the same explanation, the same picture. This is one strain of influenza A, this is another one, and the different segments may be reassorted and new variants, new strains are produced. Influenza appears in epidemics, and some of these epidemics become pandemics. You already know the meaning of pandemic. A pandemic is an epidemic that spreads to the whole world. The last one was 10 years ago, but the most severe, the most dramatic pandemic appeared 100 years ago. During this pandemic, 100 years ago, it's estimated that between 50 to 100 million people, in the world died because of this pandemic. This is one of the worst pandemics in the history, one of the worst. Look, between 50 to 100 million deaths. To compare, for example, the current pandemic that we suffer with the new coronavirus, until now, the deaths in the world are less than 100,000. Until now. Look, this pandemic of influenza 100 years ago, between 50 to 100 million people died. And these people that died 100 years ago, most of them were very young, younger than 65 years. This is the worst one. As I told you before, the most important antigenic shifts appear every 8 to 10 years. The last one in the year 2009. So this is a list with the most important epidemics and pandemics in the last 100 years. And the worst one was this. This pandemic 100 years ago was caused by an H1N1 influenza A strain. The last pandemic appeared 10 years ago. Maybe you don't remember. This one was another H1N1, but this one was different to this one. The last pandemic 10 years ago was not so severe. It was mild, moderate pandemic. Not many people died. The transmission of influenza viruses is by droplets. You already know. This is the most common way of transmission. So, inhalation of droplets, contact of droplets with mucosas. And the target host cells infected are ciliated respiratory cells, epithelial cells at the respiratory tract. Look, these ciliated respiratory epithelial cells are found in the whole respiratory tract, and the function of these cells, the function of this cilia, is to remove dust, to remove microorganisms with the movement of the cilia. That is the function. These are the cells infected and destroyed by influenza viruses. The infection by influenza viruses is lytic. So these cells are destroyed. So look, this is the pathogenesis of influenza. The pathogenesis of influenza is not easy to understand because the damage, as always, depends on two factors. Damage depends on the virus and damage depends on the immune response. Both. So look, we start with exposure. exposure through droplets. The virus, at the beginning, infects the ciliated respiratory cells. And the virus destroys these cells because this infection is lytic. So these cells are desquamated. So we show symptoms that we call influenza-like symptoms. So cough, runny nose, sore throat, this is called influenza syndrome. And this is produced by the virus. When the virus is replicating at the respiratory tract, the immune system starts working. And the immune system, the innate immune system and the adaptive immune system, both start to fight against the infection. What about the innate immune system? Remember, the innate immune system contains cells and molecules, and one of them are interferons. Interferon alpha and interferon beta. Interferon alpha and interferon beta are important molecules to fight against viruses. In the second class, I told you that this is called antiviral response, that we didn't study because we didn't have time to explain immunology. You will understand next year. So, innate immune system, interferons. Interferons are antiviral molecules, but they also increase the symptoms by different mechanisms. So this is the innate immune response. What about the adaptive immune response? Humoral and cellular, antibodies and T-cell responses. Both are important to fight the virus, and they will protect in the future, mainly antibodies. We develop antibodies against many different proteins of the virus. The most protective antibodies are antibodies against hemagglutinin, and they protect, but not forever. They protect for a very short time, 1 year, 2 years. So, immune response, innate immune response, adaptive immune response. But something more happens, something more, and not good. So look, these cells infected by the virus, the ciliated epithelial cells, are important to remove dust and to remove other microorganisms. When these cells are destroyed and disappear, the host becomes more susceptible to suffer other infections because dust and microorganisms cannot be removed from the respiratory tract. So there is an impairment of mechanical clearance mechanisms in the respiratory tract. So we become susceptible to suffer other infections. So this is not common, but severe. Some patients that suffer influenza, few days later, they may become infected by a bacteria, and they may suffer a bacterial pneumonia. This is called secondary bacterial infection. And this is a severe complication. So some patients may suffer a bacterial pneumonia, for example, by Streptococcus pneumoniae, following influenza virus. And this is a severe complication. Other patients may suffer pneumonia by the virus itself, by the influenza virus. And this viral pneumonia is also severe. This is what happened 100 years ago with the dramatic pandemic that I told you. And some patients may have complications in another organs related with the immune system that I cannot explain because I don't have time. So look, the pathogenesis of influenza is very complicated. So I show you here a summary with all findings. Viruses, influenza viruses, damage epithelial cells directly, and these ciliated epithelial cells are destroyed. The respiratory epithelium is destroyed. What about the immune system? Acute inflammatory response. So damage also depends on the immune system, the innate immune system and the adaptive immune system, both. Because the epithelial cells are destroyed, there is an impairment of the mechanical response. The clearance mechanism, the cleaning mechanisms of the respiratory tract are impaired. So the host becomes susceptible to suffer other infections. That is the reason why some people may suffer bacterial pneumonia. And finally, there is also an impairment of the immune response. This is related with some proteins produced by the influenza virus. Some proteins produced by the influenza virus, by different mechanisms that we are not going to explain, can inhibit some functions of the immune system. Some proteins can inhibit phagocytosis or chemotaxis or other functions that we can't explain. Some proteins. And because of this, the immune response against other pathogens is impaired. So these also increase the risk of suffering other infections. So in summary, all this damage makes the host very susceptible to suffer other infections, mostly bacterial infections. I told you that the infected host develops antibodies against different proteins, against hemagglutinin, against neuraminidase, and against other proteins. The most important antibodies are developed against hemagglutinin. These antibodies protect, but not very much, as I told you. They protect for a limited period of time, depending on many different factors. So these are the most protective. The host also develops antibodies against the neuraminidase, but they are less protective. And what is influenza? This is not microbiology. This is internal medicine, but I have to say some words to explain what influenza is, because if we don't know what is influenza, the explanation about the virus is useless. So I have to explain you something about influenza. This is not microbiology. Influenza is a respiratory disease. When we become infected by influenza virus, we develop symptoms after 1 to 4 days. This is the so-called incubation period. After that, we start showing non-specific symptoms. These non-specific symptoms are very common for many different viral diseases. Headache, fever, chills, myalgia. Myalgia is very important, so I show you with a different color, because myalgia may be found in many different viral diseases, but it's very typical in influenza disease, very typical. After these non-specific symptoms, the patient may show respiratory symptoms. Influenza is a respiratory disease. So patients may suffer cough, sore throat, and other respiratory symptoms. Sometimes we can suffer conjunctivitis, photophobia. We can feel burning on the eyes. And children may have gastrointestinal symptoms like vomits or diarrhea, but we don't know exactly why. Most people who suffer influenza suffer a mild disease, very mild. They recover in very few days. In less than 5 days, people are recovered. However, the cough may persist until 2 weeks. So even when the patient has recovered, the cough may persist until 2 weeks. Why? Because the ciliated epithelial cells have been destroyed and they must be renewed. That is the reason why people recovering from influenza may cough for 2 weeks, even when they have recovered from the disease. This is the typical mild influenza. However, I told you that some people may suffer complications because people become more susceptible to suffer other infections. The most common is secondary bacterial pneumonia. So pneumonia caused by bacteria. This is the most common and the most severe complications, usually by Streptococcus pneumoniae. This is the most common one, but also by Haemophilus influenzae or Staphylococcus aureus. The most common one, Streptococcus pneumoniae. I told you before that some people may suffer a viral pneumonia caused by the influenza virus itself. And other people, not commonly, may suffer other complications related with the immune system that we are not going to explain because we don't have time. You will study in the future in internal medicine. This is related with the immune response. The general rule is that people with influenza suffer a mild disease. Some people have higher risk to develop complications of influenza. For example, small children, or the elderly, or people with chronic diseases, or pregnant women, or obese people, and others. So these groups of people may suffer severe complications. So vaccination is mainly recommended for them. People with mild disease do not require any treatment. The treatment for mild people is only symptomatic. So to decrease the fever, to treat the myalgia if needed, and fluid replacement therapy. Only that. Currently, we have antiviral drugs to fight influenza viruses, but these antiviral drugs are only used with some people, only with some people. Antiviral drugs to fight influenza may be classified into 3 groups. The first one, the first antiviral drugs that appeared were more than 20 years ago. Is this group that I show you here, M2 protein inhibitors, amantadine and rimantadine. They appeared more than 20 years ago, and they were useful 20 years ago, but not now, because currently all influenza A viruses have become resistant. So currently this group of antivirals is totally useless. Currently, we have inhibitors of the enzyme neuraminidase. Remember neuraminidase. This is the enzyme, the glycoprotein found at the envelope. This is an important enzyme to release the virus. Currently, we have 3, zanamivir, oseltamivir, and peramivir. Peramivir is very recent. It appeared about 2 years ago. The others, zanamivir and oseltamivir, appeared 10 years ago. They are expensive, and we only use them with people with severe disease. And 1 year ago, we have another one that inhibits the transcription of RNA. It's called baloxavir. This one is available only in some places. It was approved 1 year ago in Japan, but we don't have much experience now with them. So the most common antivirals that we use against influenza are the inhibitors of the enzyme neuraminidase, zanamivir, oseltamivir, and peramivir. But this treatment is only recommended for people with severe disease or people who have high risk of complications, not with all the people. And we have vaccines. We have vaccines. And the vaccines are important for some groups of people. Mostly the elderly, people with higher risk of complications, medical personnel, and other groups of people. Currently, we have 2 types of vaccines. The most common one is a killed inactivated vaccine that is given by the intramuscular route. And we also have a live attenuated vaccine. By the way, the difference between the types of vaccine is found in one of the self-learning topics. Anyway, the live attenuated vaccine is a live strain of influenza, and we give it intranasally, so in the nose. These vaccines are formulated every year. So the vaccine must change every year because influenza viruses change very quickly, antigenic drifts and antigenic shifts. The vaccine contains 3 or 4 different viruses. The vaccine that we make every year contains a combination of 2 influenza A viruses and 1 or 2 influenza B viruses. These viruses contained in the vaccines are selected in the whole world, and we select the most common viruses that we find in the world every year. For example, this is the vaccine that we are using this year. This is the vaccine that we are using this year in the Northern Hemisphere, for example, in Vietnam. The vaccine that we are using this year contains 2 influenza A viruses and 2 influenza B viruses. So the vaccine this year contains 4 viruses. H1N1, H3N2, the most common influenza A viruses. This is the vaccine that we are using. But we have a problem with the vaccines. We change the vaccine every year. So we have to select a new vaccine every year. Sometimes, some years we are lucky, some years we are not lucky, because some years we don't select the viruses correctly. So this is the most important problem with the vaccine of influenza, the unexpected changes in the influenza A virus. So we have a very important problem in how to select which viruses to include in the vaccine. So the efficacy of the vaccine changes from year to year. Some years we are very lucky and the vaccine works between 70 to 90%. However, other times the efficacy is very low, between 40 to 60%, because influenza changes very quickly. So look, I am going to show you the video about the influenza infection. Wait a moment. Wait a moment, because I can't find. Wait a moment, sorry. Here. Okay, so look, influenza viruses, the microbiology and the pathogenesis is very difficult to understand. So the most important thing to understand the epidemiology and the vaccinology of influenza viruses is to understand how influenza viruses change. In this video, I show you what happened 10 years ago during the last pandemic. In this video, I show you the antigenic shifts that appear every 10 years. So look, here we have 2 hosts. We have a human infected with one virus, and we have a chicken infected with another virus. And look what happened. Another host, a pig in this case, was infected by both viruses at the same time. The virus from the human and the virus from the chicken. They have 8 segments each one. And unfortunately, reassortments of segments appeared and a new strain was produced. So this is a new strain. So inside the pig, a new strain was produced, totally different to the strain from the human and totally different from the strain from the chicken. So this one is H5N2. Remember, the human was infected with an H3N2. The chicken was infected by an H5N1. This one is new. This strain is new. This was the origin of the last pandemic, a new strain that was produced in an animal host. And this new strain infected humans and caused a pandemic 10 years ago. This is the mechanism why pandemics of influenza appear, usually every 10 years. So, any question about influenza? This is very important. Understanding the changes of genetic content is very important. Any question?
Teacher.
Yes.
In many countries, especially in the USA, so they always recommend the people need to use the doses for the influenza. So is it the vaccine or the drugs to you?
Sorry? Can you repeat?
In the USA, they
Yes.
always recommend the people need to use the doses of the influenza, maybe 1 month a dose or 2 months a dose. So I don't know, this is the vaccine or the drugs.
The vaccine is given only 1 dose a year. Well, to my knowledge. About the antiviral treatment, I don't know. I don't have experience with the antiviral treatment because it's not common. But the vaccine is given once a year. The vaccine is given at the beginning of the epidemic outbreak. So the vaccine is given, for example, in my country, the vaccine against influenza is given in October, November at the beginning. In Vietnam, I don't know. I have no idea when, but it's given in 1 dose.
So every year we need to use the vaccine?
The vaccine is needed every year, a new vaccine. And the vaccine currently is not recommended for all the people because influenza, as a general rule, is a mild disease. So the vaccine is recommended for people with high risk of developing severe disease or for people who have to take care of other people. So currently, the vaccine, to my knowledge, is recommended for very old people, for people with underlying diseases, for pregnant women, and for medical personnel. For medical personnel, even if we are healthy. So for medical doctors and nurses, the vaccine is recommended because it's very important that we don't suffer influenza for 2 reasons: to avoid the spread to the patients and to avoid staying at home. So the vaccine is not recommended for all. The vaccine is recommended for some groups of people. And we need to be vaccinated every year with a different vaccine. That's the problem of the vaccine, that we need a vaccine, a new vaccine every year. Questions?
Excuse me?
Yes.
It is possible that we will find another neuraminidase or hemagglutinin, the strain that we never seen before.
A new one, yes, it's possible. It's possible. Actually, the list of hemagglutinins and neuraminidase is increasing. So some years ago, we had only 15 hemagglutinins. Now we have 18. They appear because of mutations. So the new hemagglutinins and new neuraminidase appear because of mutations. So yes, the list of hemagglutinins and neuraminidase will be increased in the next years. They are increasing. Yes, that's possible.
Thank you.
More questions? Actually, that is the antigenic drift. An antigenic drift is a mutation in the hemagglutinins or neuraminidase. Yes. Questions? Koha, do you want to say something? questions?
No.
Okay, so we stop 5 minutes, okay? And after 5 minutes, we will continue with the family Paramyxoviridae that is very similar, okay? So we stop 5 minutes. Okay, so we continue with the class.
Yes.
Okay, so we continue now with two respiratory pathogens that are very similar to influenza, and they belong to the family Paramyxoviridae. The family Paramyxoviridae contains many different viruses. Important for humans are 5. In this class, we are going to study 2 respiratory pathogens, parainfluenza virus, and later respiratory syncytial virus. These are the respiratory pathogens that we are going to study in this class. In another class, we will study mumps and measles, but this is for another class. The family Paramyxoviridae is very similar to the family Orthomyxoviridae, very, very similar. They also have negative single-stranded RNA. They have a capsid that is also helical, and they have an envelope. And the envelope also contains glycoproteins. One of them is very similar to the hemagglutinin and neuraminidase of Orthomyxoviridae. And this is the protein that the virus is used for binding host cell receptors. Okay, so the family Paramyxoviridae. In this class, we studied 2 viruses, parainfluenza virus and another one, respiratory syncytial virus, for later. Para means besides in Greek language, okay? Parainfluenza. Please don't confuse with influenza. Influenza and parainfluenza are different viruses, okay? Similar but different. Parainfluenza viruses, we have 4 types, 1, 2, 3, and 4. You don't have to remember this. This is not important for you. All of them are respiratory pathogens, all of them. They are also transmitted by droplets, by the same mechanisms as influenza viruses. They infect epithelial cells of the upper respiratory tracts. The upper respiratory tract. These cells are not exactly the same as the cells infected by influenza viruses, but they are found in the same place. They are respiratory pathogens at the upper respiratory tract and at the lower respiratory tract. Mostly at the upper respiratory tract and mostly mild. Sometimes they may become severe if the infection is at the lower respiratory tract. These viruses are very common, very, very common. Look, I told you that we have 4 types that you don't have to remember, but I have to tell you that type 3 is the most common. So look, in children younger than 5 years, almost 100% of them have been infected. So look, almost all. And in children younger than 1 year, so in infants, about 50% of them are infected. Very common. Type 3. The other types, type 1 and 2, are not so common, but they are also very common, almost 75%. And type 4 is maybe the least common, but they are also very common. So, respiratory pathogens for children and respiratory pathogens for adults, mostly for children, usually mild. So look, at the upper respiratory tract, these are the most common diseases. A typical disease that they cause is laryngotracheitis. So an inflammation of the larynx and the trachea. In English language, this is called croup. The medical name is laryngotracheitis, upper respiratory tract infection, usually mild. However, when these infections appear at the lower respiratory tract, they may become more severe. The most severe is pneumonia or bronchiolitis. So, you already know pneumonia because we have talked a lot about pneumonia. This is the disease. We will explain bronchiolitis later because the most common cause of bronchiolitis is not parainfluenza virus, it's another virus. Here, we are going to explain some things. This is not microbiology, This is internal medicine. We are going to explain some things about croup, about laryngotracheitis, because the most common cause of laryngotracheitis, croup, is human parainfluenza viruses. So laryngotracheitis, croup in English, is a typical disease of children, typical disease. And when you go to the hospital and practice in the pediatric department, you are going to meet children, I don't know if every day, but every week with laryngotracheitis. This is very common. So inflammation of the larynx and inflammation of the trachea. So swelling. So the airway is a little bit closed. So the typical findings are related with this. A child with laryngotracheitis is a child with stridor. What is this? This is a sound, I will show you the video later. This is a sound that we hear when the child is inspirating because the airway is closed. Hoarseness because of the inflammation of the vocal cords. Barking cough. And if the laryngotracheitis is very severe, if the airway is very closed, the child may show dyspnea or recession. Laryngotracheitis, the symptoms of laryngotracheitis usually appear at night. And this disease is usually very mild, and children recover in less than 2 days. So look, this is laryngotracheitis. I will show you. Wait a minute. Wait one moment. I'll show you the video. Look at the child and hear at the child. Can you watch the video? Can you watch the video?
No.
No? Okay, wait. Can you watch the video? I can't see.
Still nothing.
No?
Yeah, no.
Okay, wait. What? So I can't hear. Wait one moment. Can you watch the video?
No.
No?
No.
Oh, okay, wait a moment. I don't know why. So what are you watching now in your screen?
Yes.
What are you?
Presentation.
The presentation, okay. And now?
The baby.
The baby, okay. So I'm going to check again. So can you watch the video now?
Yes.
Okay. So please, and can you listen? Can you hear the baby?
Yes.
Okay. So here, the barking cough. Can you hear how the baby is inspiring? Can you hear the estridor? The estridor. The
No,
estridor.
I
Here.
just hear the cough. I can't hear the.
Yes. So you have to pay more attention. So the estridor is the sound when the baby is inspiring. So when the baby is breathing, inspiration. The estridor appears in inspiration. I play again. Can you hear?
Yes.
The stridor,
The
because we are
connection is quite unstable, so we can see the video clearly. Oh,
okay.
no, smoothly.
Okay, there's a problem with the connection. Okay. Anyway, you have this video in the link. Okay, I show you now, but you can download this video from the link that I gave you 3 months ago. So you have to check in the video. You have to check 3 things. You have to check the calf, the barking calf. You have to check the stridor, and you have to check the chest recession. The chest recession appears when the disease becomes more severe, when the airway is closer. Okay. So wait, we go back to the presentation. So we are here. So stridor. Stridor is the sound that appears on inspiration. This sound appears because the airway is closed, not very close. Barking calf, also in the video, okay? And you can check recession. This is laryngotracheitis. This is a typical disease of children, typical disease, and you are going to meet many children with laryngotracheitis. I can't move now there. Wait a moment. Because I have a problem here. Wait one moment. Can you see the presentation? Can you see the presentation?
Yes.
Yes. Mọi người.
But I can't move the presentation. I don't know why. Wait, please wait a little bit. Wait one moment, okay, please, because I have a problem here. Okay, can you see the presentation now?
Yes, clearly.
Okay. So that is laryngotracheitis. The most common cause of laryngotracheitis in children are parainfluenza viruses, okay? We don't have any antiviral to treat laryngotracheitis, to treat parainfluenza viruses, and we don't have any vaccine. Currently, there is some research to test some vaccines against type 3 and type 1, okay? In Vietnam, these viruses are also very common, and it seems that in Vietnam, the most common parainfluenza virus is type 3, and maybe also type 4. This is a study conducted in Nha Trang some years ago. Okay, so maybe in Vietnam, type 3 is also the most common, the same as all over the world. Okay, and now the other one. Inside the family Paramyxoviridae, we also have the respiratory syncytial virus. And this virus is very important. This is the most important respiratory virus in small children. This is the most important, the most common respiratory virus in infants, the most important, also in Vietnam. Respiratory syncytial virus is the cause of upper and lower tract respiratory diseases. So the same, another respiratory pathogen. Currently, as I told you, the most important respiratory pathogen in infants, the most important. Respiratory syncytial virus is the most common cause of bronchiolitis. Bronchiolitis is a lower respiratory tract disease. and inflammation of the bronchioli, the most important. And very common, look, around 50% of children younger than 1 year, so infants, are infected. After 3 years, so I mean, children 3 years of age, almost 100% have been infected. The most important and the most common respiratory pathogen in infants. Also in Vietnam. In Vietnam, respiratory syncytial virus is the most commonly detected respiratory pathogen in children in hospitals. The most important. The transmission is the same. The transmission is through droplets. Inhalation of droplets, contact with droplets into the eyes or in the nose or in the mouth. And this virus is very transmissible, is very contagious, more than influenza and more than parainfluenza. This is one of the most contagious viruses. It may appear in outbreaks. So, for example, if the virus is introduced in a kindergarten, after a few days, all children are infected, all. So this is another virus that we get when we go to school for the first time. So I tell you again, in few years, when you become parents and you have children, your children will be sick almost every week with different viruses, with parainfluenza, with influenza, with respiratory syncytial virus, with herpes simplex, with Epstein-Barr, a lot. And don't be afraid, because that's normal. During the first months, when your child goes to school, almost every week, they are going to be sick with any of these viruses. And this one, the respiratory syncytial virus, is one of the most contagious, the most important. The damage, we don't say anything about the damage. It also depends on both, on the virus and the immune system. The same as parainfluenza, the same as influenza. Both mechanisms are related with damage. And this is not microbiology, but I have to tell you, in infants with bronchiolitis by the respiratory syncytial virus, they may have plaques in the smaller airways, so in the bronchioli. These plaques contain mainly mucus, necrotic cells, and proteins. And this is the reason why the children may have dyspnea and breathing may be difficult sometimes because of the plaques in the smaller airways. So this is a very important pathogen in infants. So in children younger than 1 year, the most common disease that they cause is bronchiolitis. And in these children younger than 1 year, bronchiolitis is more severe. The virus can infect older children or even adults, but in older children or adults, the disease is mild. However, in infants younger than 1 year, the disease is more severe. And this is not microbiology. This is clinical medicine, again, but I have to tell you what bronchiolitis is. Bronchiolitis is a lower respiratory tract disease in children, mostly in infants, children younger than 1 year. This is the most common serious respiratory infection in childhood, the most serious, usually in children younger than 1 year. Children with bronchiolitis have also cough, tachypnea, recession. This is common. This finding is common for all respiratory diseases where the airway is closed, recession. Hyperinflation of the chest. This is related with the plaques in the airway. And patients with bronchiolitis, children with bronchiolitis, also show wheezes, a sound when they are breathing, but mostly during expiration. So the opposite to laryngotracheitis. Remember in the video, in children with laryngotracheitis, The sound when breathing appears mostly in inspiration. However, in infants with bronchiolitis, the sound when breathing appears mostly during expiration, the opposite. This is a baby with bronchiolitis. I will try to show you. Wait a moment. So look, in this video, you have to check the sound. You have to check the recession of the chest, the suprasternal recession. So look, I hope you can see it. Wait a moment. Can you see the video?
Yes.
The baby? Yes? Okay. So look, this is a case of severe bronchiolitis. Look here. Look here. Look the recession here. I show you with the arrow. Look now. Can you notice the recession here? Can you notice? Yes or no? Silence.
Yes.
What? Sorry?
Can you play the video once again?
Yes. Can you notice the hole here, the recession? This sign of recession is related with severity. This baby suffers a severe bronchiolitis. Well, severe. Not very severe, but a little bit. Look. Can you notice the recession here?
Yes.
Yes, it's like something is blocking his airway.
Yes, that is a recession. Okay, that's related with an obstruction in the airway. So the airway is closed and the baby can't breathe very well. So in this video, you have to notice two things. You have to notice the recession and you have to notice the sound when breathing in expiration. Like, and you notice?
Yes.
Look. Okay, enough. So that's bronchiolitis. Typical disease of infants younger than 1 year. And you are going to meet many children with bronchiolitis in pediatrics. It's very common. So wait one moment. Try to go to the presentation. So we are here, bronchiolitis. Okay, that is bronchiolitis. So I'm going to sort this information a little bit. So we have respiratory pathogens. Respiratory pathogens from the family Paramyxoviridae. And we have studied two respiratory pathogens from the family Paramyxoviridae. Human parainfluenza viruses. We have 4 types. The most common in the world is type 3, and they cause respiratory infections at the upper respiratory tract and the lower respiratory tract. Upper respiratory tract and lower respiratory tract. The most common at the upper respiratory tract. Both upper and lower may appear in children or in adults, both. We have focused in children because these diseases are very common in children. In children, the most typical disease, the most typical caused by parainfluenza virus is laryngotracheitis. In English, this is called croup. In children, parainfluenza viruses also cause bronchiolitis. But the most common cause of bronchiolitis in children is not parainfluenza viruses, is respiratory syncytial virus, okay? So, human parainfluenza viruses, laryngotracheitis and bronchiolitis. The most common, laryngotracheitis. Group. So, laryngotracheitis, the child is coughing, as I show you. So, cough, the barking cough. Barking cough is like a dog, barking cough. Stridor. Stridor is the sound when inspiring. Hoarseness. This is not microbiology, okay? This is pediatrics, but I have to tell you. Hoarseness and sometimes dyspnea. Dyspnea with recession sometimes. This is laryngotracheitis, okay? Usually produced by parainfluenza viruses. Respiratory syncytial virus. We have two types that we are not going to study, okay? It's not important. Respiratory syncytial virus also cause upper respiratory tract infections and lower respiratory tract infections. The most important, lower respiratory tract infections. This is also a pathogen of children or adults. More severe in children. Usually in children younger than 1 year. And the most common disease is a lower respiratory tract infection, is bronchiolitis. This is the most common disease. Sometimes pneumonia, but pneumonia is not so common. So the common is bronchiolitis. So look, bronchiolitis may be caused by many different viruses. Respiratory syncytial virus, parainfluenza, influenza, and others, okay? But the most common cause is respiratory syncytial virus. So what is bronchiolitis? Bronchiolitis is a respiratory tract infection and typical of very young children with cough and the sound when breathing. Sound when breathing, but this appears in expiration. So the opposite to laryngotracheitis, dyspnea with recession sometimes. And well, this is the most important, okay? So look, so we have two respiratory viruses important for children, okay? Laryngotracheitis, parainfluenza viruses, and bronchiolitis, respiratory syncytial virus. So look, bronchiolitis is also a mild disease. Only sometimes bronchiolitis becomes severe. So most people, children or adults, only require symptomatic treatment. For many years, ribavirin, this is an antiviral that I explained you in the self-learning topic 5. For many years, ribavirin was the treatment of bronchiolitis. But currently, ribavirin is not recommended. Only sometimes. Maybe ribavirin may be recommended for immunocompromised people, but the current guidelines say that ribavirin is not recommended. We don't have a vaccine, but research is upon development to try to find vaccines. Bronchiolitis by respiratory syncytial virus is usually very mild. However, some children, usually preterm infants, do you understand preterm? That they are born before time. Some children, like preterm infants, may suffer a very severe disease. So for these children, we can use pre-exposure prophylaxis, not with the vaccine because we don't have a vaccine, but we can use antibodies, passive immunization, for pre-exposure prophylaxis in these children. In the past, many years ago, we could do this with antibodies, with immunoglobulins. Currently, some people do it with monoclonal antibodies that are called palivizumab, but this is very expensive, and this is only possible in some places. But I don't want to explain this in detail because this is not microbiology. Okay, so you will study in pediatrics. Just to tell you that pre-exposure prophylaxis is possible for some children, but this pre-exposure prophylaxis is made with antibodies, okay, not with the vaccine. And finally, to finish the class, we are going to study the family Coronaviridae, the coronaviruses that are so popular now. Coronaviruses are not new. Coronaviruses were discovered more than 50 years ago, and they are very common viruses for humans. They are not new. They are usually respiratory pathogens, and they are the second most common cause of the common cold in humans. Coronaviruses are transmitted by the respiratory route through droplets, contact with droplets. So inhalation of droplets, contact with mucosas, with the eyes, with the mouth. Some people say that some coronaviruses may be transmitted through the air, airborne transmission, but only some coronaviruses. Other coronaviruses may be transmitted by the fecal-oral route, some, but very few. And they are very important human and animal pathogens. They are very common in human infections, very, very common. So look, coronaviruses may be classified into 4 different genera. We know many different coronaviruses, many different. So when I explain this class, because coronaviruses are not new, okay? When I explain this class, I divide the coronaviruses into 2 types, into 2 groups. The old coronaviruses and the new coronaviruses, okay? So the old coronaviruses, like this one, or this one, or this, they were discovered a long time ago, and they are very common in the world for a long, long time. The new coronaviruses appear in the last 15 years, okay? So look, the old coronaviruses, they cause usually mild diseases. They are related with upper respiratory tract infections, usually the common cold. But we are not going to say anything about them. However, in the last 18 years, new coronaviruses have appeared. And these new coronaviruses are all of them zoonotic. So from animals to humans. And these new coronaviruses cause severe disease, sometimes, not always. The first coronavirus, the first new coronavirus that appeared was in China 18 years ago. And that was the so-called severe acute respiratory syndrome. This was a very severe disease, very severe, maybe the most severe, caused by coronaviruses. And many people died because of this virus. However, the transmission was not so easy as the new one. So this was the first one. And this was an epidemic that appeared mostly in Asia. With the origin of this the origin of this epidemic was in China. The second one appeared 7 years ago, and it was called Middle East Respiratory Syndrome, also zoonotic. This one appeared in Arabia, in Saudi Arabia, in the Middle East. And the mortality of this virus was very high. The transmission was almost only zoonotic. Person-to-person transmission was not very clear. But the mortality was very high, as I will tell you later. And the last one appeared 3 months ago, as you already know. The last one, the SARS coronavirus 2, is very similar to the first one, very, very similar, but much milder, not so severe as the first one. However, the new one, the transmission of the new one is much easier. That is the reason why the new one has spread to the whole world and caused a pandemic. So this was the first one, the severe acute respiratory syndrome, the SARS coronavirus that appeared in China 18 years ago. It appeared in November of 2002 And there was an alarm in the whole world because the disease was very severe, very severe. We found cases in China, in Canada, in Hong Kong, in Taiwan, in Singapore, and also some cases in Hanoi, but not many. This was zoonotic from bats and transmitted to humans through another animal that we don't know very well. It was also transmitted in droplets. However, the disease was very severe. The disease was very severe and with 10% of mortality. This is very, very high. However, the epidemic was efficiently controlled, so it didn't become pandemic. The last case occurred in 2004, and we didn't have any more cases after that date. The second pandemic appeared 7 years ago. I remember this, sorry, not pandemic, epidemic. The second epidemic appeared 7 years ago, and I remember very well because this epidemic appeared when I was teaching in Indonesia, and we were very worried about this epidemic. I'm not sure if you remember this. This epidemic, Middle East Respiratory Syndrome coronavirus, appeared in Saudi Arabia, and the mortality was very high. 34% of people infected died, but not many cases. And this was also zoonotic. Possibly the animal that transmitted the disease was a camel, and human-to-human transmission was very rare. Was possible, but very rare. So even when this virus is very severe, the transmission of the virus was very difficult because human-to-human transmission was not so common. This is the evolution of the epidemic of MERS, the MERS coronavirus. When the virus appeared, when I was teaching in Indonesia, I was teaching here in the year 2014. And we were very worried, very, very worried, because many cases were appearing in the Middle East, but also in Korea. Korea suffered many cases of the MERS coronavirus. One of the reasons why Korea has been very successful controlling the new coronavirus disease, the COVID-19 now, is because they have a lot of experience with this epidemic some years ago. They have a lot of experience, so they can fight more efficiently. This epidemic of the MERS coronavirus has been found until half of 2019. So this virus maybe has not disappeared yet, the MERS coronavirus. And the last one, the new coronavirus, very similar to the SARS. By the way, the name of the virus is SARS coronavirus 2. The name of the disease is COVID-19. Not exactly the same, but almost the same. This virus appeared 3 months ago in China. You already know, in the city of Wuhan. This coronavirus is also zoonotic. And we don't know exactly the animal that transmits the disease, but we know that the disease is not very severe because most cases of the disease are very mild. However, the problem of the new coronavirus is that the transmission is very easy. The virus is very easily transmitted from human to human, and that's new. So the problem of this virus is that the transmission from human to human is very easy. That is the reason why this epidemic has become pandemic. The last information of this class was updated 1 week ago. And 1 week ago, we had almost 1 million cases in the world, with 200 and something in Vietnam. The mortality all over the world is less than 5%. And currently, most cases are found in the US. The pandemic in the US is going to be terrible, maybe the worst in their history. Currently, most cases appear in the US. And most deaths, as you already know, have been found in Italy and Spain. So look, this is the evolution of the pandemic until 1 week ago. In the beginning, cases appeared only in China. However, in the last month, in the last 30 days, the pandemic spread to Europe first and later to North America. So currently, most cases are found in North America. Coronaviruses have envelope. This is the structure of a coronavirus. The name corona is a Spanish word that means crown. Corona is because of the appearance of the envelope, and they have glycoproteins at the envelope, and one of these glycoproteins is the glycoprotein used by the virus to bind host cell receptors. This is the structure. Single-stranded RNA, positive sense. Remember, positive sense means that they have the same nucleotide sequence as the messenger RNA with capsid, helical capsid. And well, this is the structure of all coronaviruses, okay? This picture that I show you is for all coronaviruses, the old coronaviruses and the new coronaviruses. So we are not going to explain specifically the structure of the new coronaviruses. What about the new one? What about the new coronavirus? The structure is very similar to the SARS coronavirus that appeared in China 18 years ago. They bind the same receptors. They are very, very similar. The new coronavirus is found into two types. So currently we know that the new coronavirus is found into two types, with some mutations, but not many until now. The route of transmission of the new coronavirus, we don't know very well because we don't have much experience. It seems that in the beginning, the transmission was zoonotic. We don't know the animal, but we know that the first cases of the new coronavirus appear in a seafood market in the city of Wuhan. This is what we know. Zoonotic transmission from animals to humans. And later, the transmission was from person to person through droplets in a very similar way to influenza, very, very similar. So inhalation of droplets, contact with droplets with our hands to our face, and the RNA of the virus has been also found in blood and stool. But it seems that the transmission from stool is not possible, but we are not very sure. So fecal-oral transmission seems not to be important, okay? We find the RNA in stool because we find the RNA of coronaviruses of many coronaviruses in stool. But it seems that this is not, the transmission from stool is not possible, but we are not totally sure. And vertical transmission, transplacental transmission, is possibly unlikely. So we are not sure yet because we don't have experience, but it seems that transplacental transmission is not possible. So currently we know that transmission of the virus is through droplets. And we have a very serious problem with the SARS coronavirus. And what's the serious problem? It's something that is good and bad at the same time. Why good? Because there are many people totally asymptomatic, because most people who suffer the disease are very mild or even asymptomatic. And this is also bad. This is also negative. Why? Because it seems that asymptomatic people or people with a very mild disease can also transmit the disease. This is the problem. So, and this is very difficult to control, because if most people are asymptomatic or very mild and they can transmit the disease, it's very difficult to identify these asymptomatic people. This is one of the reasons, maybe the most important reason, why the epidemic has become pandemic, because the spread has been very easy from asymptomatic people. This is the problem that we have now, that asymptomatic people or very mild can transmit the disease. This is a problem, and we don't know very much about this yet. We don't know. It seems that the incubation period of the disease is until 14 days, but people usually have incubation periods of 4 to 5 days. This is the usual incubation period. And many cases asymptomatic. Many cases. We don't know how many because it's impossible to identify how many. In some studies that we have performed in Spain in the last month, in Spain now we have almost 200,000 cases, but some people say that maybe infected people in Spain are much more, maybe millions of people, maybe. So we don't know exactly how many asymptomatic people we have. And that is a problem because asymptomatic people may transmit the disease, but maybe less than symptomatic people. And what about symptomatic people? Most people are very mild. So around 81% of people will suffer a very mild disease, like a common cold. Severe disease is only found in 14% of people. And critical disease, very severe, who require ICU, is around 5% of people. So most cases are very mild or even asymptomatic. The mortality seems to be 2.3%, but maybe the mortality is much, much lower because we don't know the number of asymptomatic people, okay? But with the data that we have, these data have been provided by the Chinese Center for Disease Control. The mortality now is about 2.3% of people. Most of them are old people with critical disease. No deaths in people with mild or severe disease, no deaths. And most deaths have been found in people very old or in people with underlying medical conditions. However, we also have cases of young people previously healthy that have died, but very, very few. And the disease seems to be more severe in males. We don't know exactly why. So look, most people will suffer a mild disease, a common cold, and pneumonia appears to be the most common serious manifestation, but very few people will suffer pneumonia. However, this pneumonia may be very severe. And it's very interesting because we don't have much information, but it seems that the pneumonia is related with the microorganism, the virus, but also with the immune system, with both. In the beginning, the pneumonia is not very severe. It's very mild. It's related with the replication of the virus. However, when the patient becomes very severe, it seems that severity is related with the immune response, with interferons, interleukin 6, and other cytokines. So maybe we are not sure, because it's very early to know, but maybe the severity of the disease is related with immune response, maybe. That is what happened with the SARS 18 years ago. Anyway, this is a viral pneumonia, and it's very difficult to differentiate from other viruses. In a very recent study that appeared last week, seems that the most common symptoms found in patients are fever, fatigue, cough, anorexia, myalgias, and dyspnea. These are the most common. And it seems that pregnant women are very similar, not more severe. So, because some people say the opposite, but according to this paper, it seems that pregnancy does not appear to increase susceptibility to infection or severity. Currently, the diagnosis of SARS coronavirus 2 is made at the Laboratory of Microbiology. Currently, the test that we use for the diagnosis currently means this week is the real-time reverse transcription PCR. So we take samples, respiratory samples. These respiratory samples are usually nasopharyngeal or oropharyngeal samples, or much better, sputum if we can, and we perform a real-time PCR. This is the best way to diagnose the infection by the SARS coronavirus 2. We don't have any vaccine against any of the new coronaviruses. We don't have. And what about the prevention? The prevention is very difficult because, as I told you, it's very difficult to identify asymptomatic cases. So the best prevention is to avoid contact. So different guidelines have shown methods to clean with different disinfectants and antiseptics. So, for example, cleaning with water and the usual detergents or the common disinfectants as bleach or ethanol at 70% seem to be enough to disinfect surfaces. So ethanol 70% may be used as a disinfectant or as antiseptic. Bleach, sodium hypochlorite at 150 dilution, this is a disinfectant for cleaning surfaces. This information is provided by the European Center for Disease Prevention and Control, and here I show you different disinfectants and antiseptics that have been useful against the other coronaviruses, and maybe they are also useful with the new coronavirus. When we wash our hands with the solutions that we find everywhere, these solutions usually contain ethanol at 70%. It's very important that when we apply ethanol 70%, we follow a good method to rub our hands. The same method that I show you in the practice to wash your hands with water and soap, the same method is possible to be used when we use ethanol or isopropanol, the same. And we don't know very much about the new coronavirus. This is the only information that I can provide you. Currently, in the last week, we know that we have some antiviral treatments that are useful against the new coronavirus, but only with some patients. But currently, we don't have much information. Any question about parainfluenza, respiratory syncytial virus, or coronaviruses? Any question?
So, do you think when we use the mask, and we can prevent the amount of the coronavirus?
The mask, well, that's a very good question. We don't know very well. The mask is not very useful to protect ourselves. It's not very useful. The mask is very useful for people who are infected to prevent the spread. So the mask is very useful for people who are already infected to avoid the transmission to others. If we use the mask to protect ourselves when we are healthy, that protection is not very good because the virus can enter through the eyes or when we touch something and then we touch the face. So the purpose of using the mask, the purpose when all the people is using the mask is to avoid the transmission to others, not to become infected. You understand? So currently in many countries, the recommendation is that all the people wear the mask. But because we don't know how many people are infected, because there are many asymptomatic people, they don't know that they are infected, that maybe they are transmitting the disease. So the purpose of using the mask is mostly to avoid the transmission to others when we are infected. To protect ourselves, we need the mask, we need a screen in the face, and we need to wash our hands very frequently. But the mask alone is not useful to protect ourselves. The mask is useful to protect others when we are infected. You understand?
So, doctor, because of the disease is not have any symptoms. So, if we have a disease, so you think you it with me? I think I don't have a disease, but sometimes it's not. So
sorry,
I think.
Sorry, I can't hear because your connection is. I think it's not good. I can't understand very well.
Okay.
Can you repeat, please?
Okay. Because the disease is not have symptomatics, but and me, I think I don't have the disease, but the
the react is not I have the disease. You understand? But I don't wear the mask, so I will translate it for the another one, and it's dangerous for another. So
the problem, yes, the problem is that we don't know how many asymptomatic people have the virus. We don't know. So it seems that the virus is also transmitted from asymptomatic people, but not so much as symptomatic people. But we are not very sure. So, for example, in China and Korea and in Vietnam, the government recommend the use of the mask for all the people because asymptomatic people who don't know that they are infected, they may be also dangerous for other people, okay? So even if we are asymptomatic, we don't know that we are infected, maybe we can transmit the virus to other people. That is the reason why it's recommended by many governments to wear the mask in public, even if we are asymptomatic. You understand what I mean?
So, I mean, we can decrease the amount of the virus. So we know if we get a lot of virus, we easy to get the disease. So about the decrease the amount of the viruses if we use the mask.
If we use the mask, if we use the mask and we are infected, the transmission of the virus is very decreased. Yes, that is the reason why we wear the mask. I mean, the most important purpose in wearing the mask is not to protect ourselves. The most important purpose is to protect other people if we are infected. Because when we wear the mask, the droplets stay in the mask and the transmission is through droplets. You understand?
Yes.
So the mask is not very useful to protect ourselves. That's the problem, that many people think that if they wear the mask, they are protected, and that's not true. The purpose of the mask is to protect other people. If you wear the mask protects you, but just a little bit, okay? So the most important way to protect yourself is to wash your hands properly. So the purpose of the mask is to protect other people if you are infected. You are protected. When you wear the mask, you are a little bit protected, but not completely protected, okay? So I am afraid that many people wear the mask, but they don't wash their hands, and they will become infected because they think that they are protected, and they are not.
Yes. So you know that the SARS-CoV and the SARS-CoV-2 is too similar, but do you know which is the most difference between them?
I am not very sure, but I think if we compare the nucleotide sequence, I think they are very similar in 60 or 70%, but I don't remember exactly. The first one was much more severe, the first one.
Yeah.
The first one that appeared in China 18 years ago was much more severe, but the transmission was not so easy as the new one. So the problem of the new one is that the transmission is very easy. That's the problem.
Yes.
Excuse me, sir.
Yes.
As I know, most of virus can work or live in the living things like human body or animal.
Yes.
Based on some information that I know, the coronavirus can live in the environment such as door handle or our clothes for
yes.
4
yes,
or 5 days. And how can?
Well, the virus are not alive, okay?
Yes.
So the